Good afternoon, and thank you for joining us today for the March Telehealth Learning Collaborative hosted by the North Country Telehealth Partnership. My name is Nancy Del Mastro, and I am the Telehealth Project Manager at Adirondack Health Institute, and I work alongside Bob Hunt and my partners at Fort Drum Regional Health Planning Organization under the North Country Telehealth Partnership supporting telehealth initiatives throughout the region. For some housekeeping, we are recording today's meeting, and that will be shared along with notes after the session this week, and we'll also include any other materials that are shared or mentioned by our presenters. We usually start our learning collaboratives with updates on telehealth policy from DOH, OMH, OASAS, and CMS. Today we do not have any updates to share, but I do want to mention that I included in the agenda, and it will be in the notes, that in January, Medicaid did release an update, DOH Medicaid update that included new e-consult guidance. Kate Bliss did mention this at a high level before that was released during our January meeting. Now that guidance is published, so that will be included in the notes document, and effective April 1st, New York State Medicaid fee-for-service will be reimbursing for e-consults, which basically answers any patient-specific questions in which a consultative provider will then discuss that with another provider instead of having an in-person visit. So more information will be included in the notes on this new guidance. And with that, we're going to go right into our featured presentation. We're going to be hearing from Ann Morgan from the Heart Network, Anne Marie Snell from St. Lawrence County Health Initiative, and Shannon VanHouse from Claxton-Hepburn Medical Center, who will all be discussing using video and virtual conferencing to increase access to evidence-based chronic disease self-management education. So I'll turn it over to the group now. Thank you all.
Great. Thank you so much, Nancy, and thank you to the collaborative for the invitation to come share our experience with you. I'm looking at the title we gave this presentation and thinking we really probably need to submit this like to a conference. This sounds very conferencey or journal. But anyway, yes, we're here to talk with you today about how our network, members of our network, have been using video conferencing to increase access to these important programs.
Is Ann muted?
I don't know how that happened.
Yeah.
Sorry. Thank you. Do you hear me now?
Yes.
Yes,
Okay.
thanks, Ann.
Yeah, you're welcome. So here's your panel. I'll be talking about the Get Healthy North Country Network. Anne Marie Snell will be talking about how virtual has changed program delivery in the North Country. And then we're going to wrap it up with Shannon VanHouse at Claxton-Hepburn Medical Center, where she will talk with us about how they are actively using virtual opportunities for people to get engaged in these programs. So sorry, I'm running into a problem with advancing. Okay. So the Get Healthy North Country Network currently has about 40 organizations participating as part of the network. That includes the hospitals, the FQHCs, public health agencies, offices for the aging, and a growing number of community-based organizations that are participating with the network. The network currently covers 9 counties, big chunk of the North Country. We're just most recently starting to bring some of the Jefferson County providers, delivery organizations on board. So that's really expanding the reach, the number of organizations that are delivering programs that our North Country residents have access to. We have 10 organizations that are delivering these evidence-based programs that you'll hear a little bit about later. And the programs that are being offered, there are 7 of them currently that we have access to through either the Chronic Disease Self-Management Education Suite, the National Diabetes Prevention Program, and included in that list are the tobacco cessation programs that are available. So the Get Healthy North Country Network's mission is to reduce the burden of chronic disease across the region. And its members envision a health and social care delivery system that emphasizes prevention, not treatment, and one that offers every North Country resident equal opportunity to live their healthiest life. So I want to talk a little bit, we're getting a lot of feedback. There's a lot of confusion out there about all the different networks that are working in this area. So I'm hoping that this slide is going to help to clear up some of that confusion. The Get Healthy North Country Network is guided by what we call the Integrated Network Development Committee. And the model that our network really is looking to facilitate planning, to identify gaps, to look for, places that we need to be building up the network, is a model that was developed by the Centers for Disease Control called the Chronic Disease Prevention System. And within this system, there are 4 domains. And so when we're looking at the chronic disease prevention system in the North Country, we're looking at what's happening in the environmental domain, in the healthcare systems interventions domain, the clinic to community domain, and epidemiology and surveillance. So with the environmental domain, what we're talking about here are activities that are really working to make healthy behaviors easier and more convenient for people to engage in. So what we see happening within this domain represented through our network, we have organizations that are implementing the Creating Healthy Schools and Communities grant. We have organizations that are implementing the Advancing Tobacco-Free Communities grant. And we also have the Adirondack Food System Network represented and doing work to really build an environment that makes it easier for people to get access to healthy foods, to be able to engage in physical activity, active transportation, and to be in areas where where they're not being exposed to secondhand smoke. So it's about the policies that are being implemented, the public health policies that are being implemented to really make it easier for people to be healthy. In the healthcare systems interventions domain, we've got several activities underway. There's the Chronic Disease Care Coordination Network, which was recently funded through HRSA and is administered by Adirondack Health Institute. We have the Health Systems for a Tobacco-Free New York grant, which is really focused on how to help healthcare providers intervene when patients are using tobacco and addicted to nicotine. And food as medicine is also increasingly becoming more prevalent in this area. In the community clinic to community linkages domain, we have all of the programs that we're really focused on as a network, really focused on building, increasing opportunities, increasing availability, increasing access. That's what this presentation will be a lot about today. But again, those programs that we're really focused on right now, we're really focused on the Chronic Disease Self-Management Education and the National Diabetes Prevention Program. Diabetes is one of the priority chronic conditions that we're actually measuring. We've got a lot of data on right now. So those are the 2 priority programs. But again, we also have tobacco treatment specialists in the region. We have a New York State Smokers Quit line that everyone has access to. We have nutrition education and nutrition access programs. And we have organizations that are providing technical assistance to the organizations that are delivering or providing these services to make sure that they have what they need to deliver a successful program. As I mentioned, in the epidemiology and surveillance domain, Healthy North Country is very focused on diabetes. We've got a number of indicators that we're working with to monitor this whole system's impact on diabetes prevalence in this region. And with the Chronic Disease Care Coordination Network, there's an added focus now from the surveillance domain on heart disease. So, so this is what's happening within the network. And again, this is what we use as the Get Healthy North Country network as a planning model. Again, looking at what's happening in each of the domains and looking for opportunities to build a stronger chronic disease prevention system. The 1115 waiver, I'm still not completely seeing where this all completely fits in, but I do think that this linkage between health systems and the community, you see a bidirectional arrow there. That's a place that we're all really working hard on right now, trying to increase that connection between clinic and community. And the systems that we use to make that happen are still, we still have lots of varied options there. There's no consistent way of doing that. And I'm hopeful that with the 1115 waiver, we're going to start to see more consistency and we're going to see better connections. So this is, in a nutshell, what the Get Healthy North Country network is all about. I would be happy to entertain any questions you might have. I think it might be better for us to hold off until the end of the presentation, or should we take questions now, Nancy, for this section?
Let's hold off till the end of the session, and then yes, anyone that has a question, feel free to pop those in the chat, or there is also a Q&A box, and I'll facilitate that after we're all done.
Okay, great. So bottom line, we are all working together, all of these different initiatives to build our North Country chronic disease prevention system. So the program delivery network, we have 10, as I mentioned, 10 organizations that are currently contracted with us to deliver chronic disease self-management, national diabetes prevention program, and we're just starting to pick up some tobacco cessation group programs as well. Just one of these organizations has the capacity to offer an ongoing year-round opportunity in the communities that they serve. Most of our delivery organizations are actually only able to offer no more than 2 programs a year. So imagine you've got someone that calls and they need an in-person program, or they, it doesn't have to be in person, but they want to get into a program. When they call, they're not wanting to wait for 6 months to get into a program. They want to get into a program soon. We want to seize the moment with them. So as the network delivery, as our network grows, organizations now collectively have the capacity to offer these at least quarterly in-person programs, but that's only in some counties. And so having organizations like Claxton-Hepburn Medical Center who are able to deliver these programs virtually is really helping to increase access to residents across the entire region, so that at any given time, an individual should be able to get into a program within no more than a month at the most. So that's what this is all about. So I'm going to turn it over. That's my contact information. I'm going to turn it over to Anne-Marie Snell at the Health Initiative to talk a little bit more with you about what this virtual program delivery has been about in the North Country.
Hello, everyone. Thank you very much, Anne, for that great overview on the network. You can go ahead and move on to the next slide. So the St. Lawrence County Health Initiative supports the network that Anne has just spoken of as the Lifestyle Program Training and Technical Assistance Center. We have 3 employees who support this. They are Jerome James, Julie Cook, and Benita Mahato. We offer training to all of our partners and often some of our statewide partners as well. Both in chronic disease self-management, and we do have the ability to train for national diabetes prevention programs as well. We do host multiple training opportunities throughout the year. We provide technical assistance to these delivery organizations that Anne has mentioned. We provide education on fidelity and fidelity checks. We provide support to our peer leaders that are trained and ensuring that they are up to date on their certification. We support the network with data collection. So that involves both training to our delivery organizations on how to collect this data, and then we act as a go-between between the Heart Network and Adirondack Health Institute, our terrific data partner. We provide support for recruitment and retention of peer leaders within these delivery organizations, and provide ongoing leader education. Additionally, we provide support in the areas of networking, working on standardizing the dissemination of classes. We provide support in recruitment, and really our champion, Julie Cook, just makes sure that these classes or these workshops can happen. We want to see our community be served in any way that we can, and sometimes that means being creative, pivoting from an in-person workshop to maybe a telephonic based on registration. So those participants who have made the effort to enroll can still be served. Next slide, please, Anne. So these evidence-based programs are licensed through the through the Self-Management Resource Center for all of our chronic disease self-management education workshops. The base of chronic disease self-management is what's called the Chronic Disease Self-Management Program. This is a 6-session evidence-based workshop designed for those dealing with some form of chronic disease. With that, it's 1 class per week and a significant time commitment with 2.5 hours per class. It's actually a 3-hour class with a break built in between. This is for 6 weeks. With that, off of the chronic disease self-management program, we have some other sessions or other programs that are really based off of the chronic disease self-management program. So we then have chronic pain. We also have diabetes self-management. We have workplace chronic disease self-management, cancer, thriving and surviving. So with all of these, we can support our peer leaders and our delivery organizations across the North Country in delivering them. Each of them will look a little bit slightly different, meaning that if a workplace chronic disease self-management program is not 6 sessions, it's designed to be a little bit easier to be implemented within the workplace. Additionally, when we pivoted to telephonic or to virtual workshops, they did change up the design opportunities for some of those. So I'll get into that once we move to the next slide. Finally, for National Diabetes Prevention Program, this is a year-long program. It is for those who are pre-diabetic or who are at risk for developing type 2 diabetes. The timing for this is that in the first 6 months, the participants will have 1 class per week and a 1-hour class. The following 6 months, they can be designed at least 1 class monthly, but most of our partners choose to have more than 1 class monthly. Really a terrific program as well, and there are standards for recognition. With both of these, there are specific billing opportunities, and Anne and the network partners are working to support identifying ways to support our delivery organizations in billing. Anne, can you move to the next slide, please? We moved from an evidence-based only in-person program to virtual delivery. I asked for the specific date with SMRC today, and they didn't have it right off for me, but they did say it was nearly immediately after the shutdown that they transitioned to training our master trainers in virtual delivery opportunities. And they are stringent. They do mimic the fidelity and the needs of the in-person only workshop. You cannot do hybrid according to their license. It is meant to be only in person or virtual. Additionally, recognizing that not everyone, especially in our rural communities, does have access to high-speed internet, they developed a telephonic toolkit, so there can be a telephone delivery. That does look slightly different for telephonic toolkit than the chronic disease self-management program was intended to be. However, we have seen great success with the implementation of that. So virtual delivery of the chronic disease self-management suite of programs is still a 3-hour commitment for our participants once per week for 6 weeks. They are providing from the Self-Management Resource Center continuous updates to support our partners to the best of our ability. We follow, we provide those updates as soon as we receive them from the licensing center. Additionally, with the National Diabetes Prevention Program, we did allow for virtual not long after the shutdown. As of now, the CDC has required that delivery organizations should register as part of their recognition program as either or in person or virtual. We are advocating for allowing for delivery organizations to do both on a regular basis and not have to register separately. We will let you know as soon as we find out more information from them on that. Next slide, please, Ian. So we have found throughout this that there are pros and some cons, but a lot of the cons and the barriers that we've seen, we've been able to overcome. First of all, during the shutdown, we were completely virtual or telephonic. So this is where you saw those barriers increasing. We could not meet in person. Now in 2024, we have both in-person opportunities. We're creating them on a regular basis, but we also continue to hold the virtual and telephonic workshops. So just one of the pros, we are able to accommodate a larger geographic area, and I'll explain that in a few slides as well. We have the opportunity to collaborate as leaders from St. Lawrence County down to Washington County to make sure that a workshop can be delivered. So you're not limited to only peer leaders within your immediate geographic region to host a workshop. Again, so that leads to promoting the partner collaboration. There are a great deal more flexibilities with participation in these winter months. Snow flurries today. It makes for a great opportunity to continue to meet despite whatever weather we have. And that time commitment barrier is reduced. You know, in our rural counties, it can be easy to only have workshops in the main population centers of the county, which can be 20 minutes or 30 minutes away from someone's home. When you consider a 3-hour workshop, that can really take a large chunk out of someone's schedule in order to attend. Our homebound individuals can now participate. It does reduce the likelihood of absenteeism due to pain or other outside influences. When you're speaking about someone who has or is caring for someone with a chronic illness, you know that that is significant. Finally, I just want to share that it does expand the accessibility of the full suite of programs. I mentioned, for instance, Cancer Thriving and Surviving. When you combine both the level of treatment that someone has, the level of pain and complications that someone might have with their cancer diagnosis, with the amount of travel that they have already to their cancer care center, and then the number who might even be interested, it really limits you to having a full class or a full workshop in any one population center. But when you expand that across the region and allow virtual or telephonic, you can have more participation. And sometimes some people have expressed, not wanting to be with the people next door. It helps them to share more when there are people spread out geographically who they probably won't run into the grocery store. They can maybe share a little bit more about their chronic self-management during these workshops. Some of the cons, the reliable internet accessibility, technology can be confusing or non-existent. I will say that I think Julie has learned and spent probably 40 hours just explaining to participants how to log into Zoom prior to a workshop. There is a limited ability to really truly see everyone. Despite training, despite the regulations that you need to have your camera on at all times, it can be difficult for everyone to really truly see everyone. We do recognize that our peer leaders do sometimes miss that personal touch. This has lessened a little bit with the opportunities that we have now to schedule in person again. There are many people, such as me, who have a challenge with their own camera mirror looking at me during my speaking. That can be a challenge and a barrier. And then just a reminder to all of our peer leaders, they, in delivering these workshops, are truly entering someone's personal space. You are now in these individuals' homes. And that is something that's really important, an important reminder to our peer leaders and our delivery organizations that when you host virtually, it can be a challenge for some individuals to invite a large group of people into their homes, such as this. We continue to see that some participants only want to join in person and are fortunate to have a nice long waiting list to support setting up those in-person workshops as close to an individual's home and driving distance as possible. And then there are technology updates or challenges consistently with any type of delivery and, you know, Zoom meetings and this lifestyle and world that we're in right now. I think you can all commiserate with that. Next slide. So I want to preface the following data by sharing that this is pulled from our data management center. We got involved with the network and really have been supporting our delivery organizations and using this data management system to the best of their ability. But really prior to 2022 even, these were not used as efficiently or effectively as we would have liked. I have full confidence in the data that I'm presenting on the number of active delivery organizations. However, when I get into the participants by county, both due to the limitations of the Compass data management system and to our process for training delivery organizations on how to enter certain data in, we aren't going to have the full entire picture. So you can see that since 2018, prior to COVID, we had about 5 delivery organizations. We are now up to, when I say active delivery organizations, these are delivery organizations that hosted at least one workshop in our data management system that year. So we had 10 in 2022 and 9 in 2023. Next slide. So number of participants and number of completers with chronic disease self-management education. This includes the full suite of offerings. So when I said chronic pain, diabetes, whether it's telephonic or virtual, this includes all of them. We have seen during the shutdown, we did see fewer participants and fewer completers. I think that was in part due to both the delivery organizations being trained and getting on board and moving forward with this, but then also participants were not prepared and were not ready to adapt to this virtual world and virtual lifestyle. But they did get into it, and we have been now offering both the in-person and virtual. And by far, 2023 did see our largest number of participants and with strong completer status for chronic disease self-management education. Next slide. And this is the number of participants in National Diabetes Prevention Program. You will note that I did not indicate completers. The way that our data management system works, it does not differentiate with large reports for completers. But our 2023 numbers were significantly higher than any prior years. And I will say that the vast majority of our National Diabetes Prevention Program participants do come from our next presenter. So I'm really excited for you to hear from Shannon. Next slide. Number of participants by county. So this is where I have a little bit of a challenge with the data that I'm sharing, but I want to show you visually what this looks like from the data management system. By year, in 2018, we were only seeing residents from St. Lawrence County in 2018. In 2019, we saw Clinton and St. Lawrence County. In 20, we added Franklin County to that mix, 21, Essex County, and then in 2023, Washington County. Now, what that doesn't show, and I'm going to pull up my data here, is that we have also seen participants join from Albany County, from Herkimer, Jefferson, Onondaga, Rensselaer, Schenectady counties. And I think that there's one more in here I want to share with you. All the way in Steuben County as well. So we do have a much broader reach than is shown on here, and I hope to be able to get to a point with our 2024 and beyond numbers to show a broader representation yet. Finally, my last comment before we move on to Claxton-Hepburn Medical Center, we are seeing, we have agreements now with Jefferson County and Lewis County organizations, as well as Oswego County organizations. When everything gets moved through and finalized after the January 1st changes that we've seen, we do anticipate seeing those workshops added and having more opportunities yet for our residents to enter into these workshops. I think that's it for me, Anne.
All right, so Shannon, you're up.
All right. Well, thank you, Anne and Anne Marie. You guys did a beautiful job covering the higher level of what's going on with these programs. And thanks everybody for inviting me to share what's going on with our program. So I'm from Claxton-Hepburn Medical Center. We have an American Diabetes Association recognized diabetes self-management program. So in addition to the Get Healthy North Country mission and initiatives, our program is also driven by standards of the American Diabetes Association and the American Association of Diabetes Care and Education Specialists. So these organizations drive the care practices of not only persons with diabetes, but those who are at risk of developing diabetes, as well as other conditions that increase complication risk for people who have diabetes. So some of these conditions are things like hypertension, cardiovascular disease, obesity, chronic pain, metabolic syndrome, a lot of conditions that are also very well managed by the Stanford suite of programs of chronic disease self-management. So with that, that's why we have also adopted not only our diabetes self-management programs, but we also have done the Stanford suite of programs, because they have just dovetailed nicely and helped to augment the programming that we've already been delivering. So thank you, Anne, for advancing the slide. So the recommendations from the organizations, the ADA and the CDCES, are that people with diabetes be seen by a certified diabetes educator or engage in a diabetes self-management program at diagnosis, at least annually, or when not meeting biomarker targets, when any complications arise, and at transitions of care in life. So that might be when a patient transitions from acute care and goes home. It could be when somebody is going from living at home to living at, say, a nursing home. It could be a pediatric patient who's transitioning into adult life. So at multiple points in their life, they recommend that patients be seen in a program. So if you can advance the slide for me. So unfortunately for our county, we have a really large geographic area, talking St. Lawrence County, that's sparsely populated and has fewer resources than other areas of our state. We also have a really strong need for disease prevention and management programs based on our comparative data. So if you look at this first slide here, St. Lawrence County is the blue line. And we have seen trends since 2016 of just a significant uptick of people diagnosed with prediabetes. And looking at the data, it is probably a gross misrepresentation of how many people actually have prediabetes, because not everybody gets diagnosed. It's, you know, as we know, diabetes is one of the silent killers. It doesn't really have a lot of symptoms, and certainly prediabetes doesn't. So very often we have patients that are walking around with prediabetes for years and don't know it. So I'm guessing those numbers are much higher. Next slide, please. And if you look at our St. Lawrence County numbers for diabetes diagnosis, we're seeing the same trends. Even from 2022 to 2023, we jumped significantly. And it's estimated that 14% of our population in St. Lawrence County has a diagnosis of diabetes. And if you go to the next slide, these are our national numbers. So that for diabetes, 1 in 10, so that's 10% of the population. So St. Lawrence County has a significant increase of diabetes incidence than our nation does. So this has meant that we've had to get creative in trying to reach our community members because of the large geographic area, because of the lack of resources. You can advance to the next slide, please. So in 2017, our department created what are called expansion sites. So that's tapping into our primary care offices to use for chronic disease management programs, diabetes self-management programs within our healthcare system, Claxton-Hepburn Medical Center. It was helpful, however, somewhat limited because it's simply just too vast. Our county is too vast to reach everyone. And it required our educators to pack up limited education supplies and travel many miles to connect with people. We also found that it was spreading our educators thinly and required travel costs for both the patient and the educator. In 2018, I worked with our grant writers and our marketing team to apply for grants that would help us give us the ability to deliver programming virtually. I was passionate about finding ways to consistently offer programming to our larger community. We actually did some site visits at some colleges that were already using telehealth technology to reach students. So we went to Clarkson and we figured out how to model our tech with theirs so that we could reach people better. Next slide. In 2019, we were awarded some significant funding from the Lions Club International Foundation, as well as our own Claxton-Hepburn Medical Foundation to create what we have today, which is a state-of-the-art conference room and classroom equipped with technology to deliver our program anywhere to anyone with internet access. The photo I took was yesterday. I happened to catch a group of nursing students that were in there doing their conference, and I asked them if I could just take their picture so that we could see how the room works. And this funding in this change, this new technology could not have come at a better time in 2019 because we all know how history played out the following year. If it hadn't been for our ability to access our patients virtually, I don't know what would have happened and how we would have stayed connected. We were able to continue to meet with folks individually and in group via our secured platforms. It almost forced us to become more comfortable with the format and ushered in a new era of our program's history. During the 2020 lockdown, I was able to continue to see 48% of patients via telehealth format, and that trend continued in 2021 with 45% of our patients seen via telehealth. If it wasn't for the addition of these services, we would have lost nearly half of our patients to care. Next slide, please, Anne. So as mentioned by Anne Marie, and she did a beautiful job detailing all of these programs, how most of these programs are run. This is just a list of the programs that we offer here. Everything that we offer is available in hybrid format, meaning that folks can join us in person or via telehealth. We've had so many success stories from our programs, and telehealth has played a major role in their success. As previously mentioned, we offer the Stanford Suite programs that are 6-week workshops. We also offer the NDPP, which we call Thrive. Thrive especially is somewhat difficult for folks to complete with different obligations, with travel barriers, with family, work, weather, things like that. So we've had many participants who were able to stay connected and achieve their goals because they were able to jump into classes from their phone. Often we'd see people, parents joining from their phones in their cars with kids at practice in the background, or people staying late at work and jumping on from their computer when they weren't able to make it. We also found that it was nice to be able to reach people in their homes. As Anne Marie said in her presentation, you do get to be in person's homes, and that can be, positive and negative, but we found it to be very positive because when you can meet with somebody in their home, you kind of can see how their day-to-day works. You get a better idea of how things work, and you can give them more practical advice as to how to manage their disease a little bit better. So it's been really invaluable. Next slide, please. So at the conclusion of every year, we hold an annual review meeting with our stakeholders and our committee. And we've been highlighting a success story from our patients. So I thought I would share with you our success story that we chose this year. We have a lot of really great stories that come out of these programs. But this one lady in particular, she did a really great job, and her story wouldn't have been as successful without the use of telehealth. So she is a 71-year-old retired teacher, and she joined Thrive in May of 2023. And she was successful in achieving her goals of not only weight loss, A1C reduction, decrease in her blood pressure meds, but her ultimate and most important goal of feeling better about herself and her health. She completed her first 16 weeks of Thrive and successfully lost 16% of her body weight, and then decided to start another 16-week session. She was again successful, but that session had ended in January. She intended to continue with another session. However, it was coinciding with the time that she would fly south for the winter to join her family. She was concerned about joining via telehealth. She wasn't really tech savvy, as I'm usually not either, but we encouraged her to give it a try. And she's currently enrolled in her third round of Thrive. We're actually over the halfway mark, so she's doing great. She's lost a total of 59 pounds. She's dropped her BMI from 40, which would put her in the obesity category, to 29 in less than 1 year. She has reduced her A1C. She's had to come off of some of her blood pressure medications because she no longer requires them. But most importantly, she reports that she feels incredible energy, strength, and vitality that she hasn't had in years. And this is really the big win for us when we talk about people's success in these programs and the impact that it can have. She recommends the program to anyone in need of this type of support and has even recruited friends to join. So I guess in sort of closing, I would just say that offering telehealth has really expanded our net to help people succeed in our community. We continue to see patients from far reaches of our county, some well over an hour away. We've even seen referrals from surrounding counties. And last year we opened communication with healthcare providers from the U.S. Embassy in Ottawa, Ontario, because they heard about the success of some of our programs and wanted to know how to tap into them. So we've seen also, as Anne-Marie has mentioned, we've seen group classes be open up for people who don't typically see themselves as, group class joiners. That's one of the things that I often get is, I'm not really a group class participant, or they'll admit that they have some social anxiety. And we've encouraged them to try telehealth, just see, keep your camera off, stay muted, just listen in and chime in when you want to. And that little bit of anonymity helps them to sometimes overcome that barrier and be able to join and be able to reap the benefits of the programming. So telehealth has been an enormous success enormous asset for our program success and our continued expansion. I would highly recommend that any organizations that are delivering these programs consider, if you're not already delivering programming virtually, our North Country community needs you. So they need us to expand into further and further reaches. And I certainly look forward to hearing whether or not they're going to allow us, the CDC will allow us to do hybrid delivery, because I think it's important to be able to do both. That's all I have. If anybody has any questions or comments, I'd be happy to answer them.
Thank you so much to all three of you, Anne, Anne-Marie, and Shannon. We do have a couple of questions that we want to hit quickly. We have about 4 minutes before we're going to turn it over to our next presenters, Karen and Erica. So first question is what are the applications and platforms that are supported for your virtual trainings or assistance? For example, Windows, Apple PC, or Android, iOS tablets and or phones, Zoom, Teams, FaceTime, etc.
For that question. So I think our delivery organizations really have embraced Zoom, but some are still using other platforms like Teams. It is up to the delivery organization. As far as like iOS platforms, you know, whether it can work with a phone or not. I know people do join with their phone, but I'm unsure of any other technology requirements. I have not had Julie or Jerome come to me and say there was a barrier because someone was using a Mac.
Yeah, I can second that, Anne Marie, that we've had participants who joined from multiple different, you know, iOS or sorry, Android or Apple or whatever. We use Google Meet. We are obligated to use a HIPAA compliant platform, and that's worked very well for us. We've also used GoToMeeting too.
Thank you. Our next question is, thanks a lot for this presentation. How has recruitment been to gain buy-in and enrollment from the participants? Are there any incentives provided to participants after completing a program virtually?
So another good question that I think is both, you know, as far as strategies for the network, I will let Anne touch on that, the network strategies to recruit participants. But I will say as far as incentives, that is based on delivery organizations. So some delivery organizations really consider the book that we provide as a companion to this an incentive. It's a great resource and something that people can turn to for years to come. We have seen, I think our partners at Claxton, I'll let you speak to what you provide for an incentive, but we have seen, you know, gift bags full of the swag from a particular organization that goes to every participant. It again is something that's up to the delivery organization for what they provide to recruit and retain their participants. Anne, do you want to speak to the network?
Yeah, I would just add to that that we actually do ask as part of, you know, if we're going to, through, you know, our funding streams, reimburse a delivery organization for delivery of a program, we do require that they offer an incentive and, you know, and ask them to report, you know, what kind of incentive they used when they, you know, when they send us the invoice for that. So lots of really interesting things are happening around incentives. I don't have that list in front of me, but I can pull it up if anyone's interested. But yeah, incentivizing is incentivized.
I can share what we've used for incentives at our organization. We've done we put together sort of healthy lunch baskets. Sometimes we put together things like portion plates and lunch totes and water bottles, and people really seem to like those things. We've also given grocery gift cards, farmers market tickets, things like that to help incentivize healthy lifestyle. We've done snow cleats, things like that to get people out and moving, snowshoes, all kinds of different healthy lifestyle equipment.
Thank you all. And that was our last question. So again, thank you for this amazing presentation. As a reminder to our participants, this was recorded and we'll be sharing the recording for anyone that wants to, you know, reference anything that was shared during the presentation. But at this time, I'm going to turn it over to Karen Ashline, who is the CEO of Adirondack Health Institute, and Erica Flint, who is the Executive Director of Fort Drum Regional Health Planning Organization, to talk quickly about the New York State 1115 waiver and the North Country Social Care Network and what our organizations have been doing to prepare for this upcoming opportunity.
Thanks, Nancy, and thanks, everyone. Great presentation about the Chronic Disease Self-Management Program. I'm going to be brief, and Nancy's going to share some slides with you after the presentation, just at a really very high level. As most of you probably are well aware, that the New York State 1115 waiver amendment was approved earlier this year. In the middle of January, the state did release a request for applications to position entities to continue to lead social care networks across their regions. There are 9 regions across New York State. The North Country region is listed here, 10 counties. And this is a fairly natural footprint for all of us to come together and again, with the Fort Drum Regional Health Planning Organization and our partners in Lewis, Jefferson, and St. Lawrence County. You know, the main focus of these social care network leads is to really look at some of our most vulnerable individuals in our communities and make sure that their health-related social needs are screened appropriately and that they're really linked with the right services so that they can be successful and that experience as a Medicaid member is as positive as possible. I would just say that for the last 3+ decades, AHI, and then with our partnership with Fort Drum, and they've been doing this work for over 2 decades, we are a social care network. We are the right entity to lead the North Country. We all live in this region, we get our healthcare in this region, and really what we want to do is enhance the work that we're already doing and continue to be the right resource for people who can't find the services they need or just really needs an extra hand or an extra person to really help them along. The state has this, their ideal vision is this focus on an ecosystem, and Anne mentioned it, that she hoped that the 1115 would continue to bring, you know, enhancement to our collaboration. I think it will. I think we've done a lot over the last 2 to 3 decades. I think there's more to do. This really develops a sustainable model for our community-based organizations who, frankly, in many regions, provide some of the most vital services to the individuals that need those services. This model, with much support over the next 3 years, will position community-based organizations to be able to bill in a fee-for-service world. With our managed care organizations, the state's been very purposeful that those dollars to support those services will be funneled through the managed care organization. So the lead's role in not only continuing to enhance and develop our social care network, but also to provide the support to our CBO partners so that they can, you know, really be able to capitalize on the dollars that will flow through the managed care organizations. You know, we've, I think, again, for over 3 decades, been doing this work across the region. I have felt, you know, over the last 2 months, it's been really rewarding to talk with partners and new to this role, but not new to the work, and just everyone's overwhelming, you know, support of AHI and the Fort Drum Regional Health Planning Organization. You know, we live here, we're a social care network, but we're so much more than that. You know, we really connect people, resources, partners, primary care hospitals, CBO, you name it. I think we've touched all of them over the last 2 to 3 decades, and just want to share that with you. I'm going to give Erica a chance to also speak, but this model is not new. This is work that we've been doing for the last, you know, 20 to 30 years. This is really taking it to a level that partners feel like they're valued, that the work that they do in our communities has value, and then to be able to reach a sustainable model where the resources are not, I would say, not guaranteed, but the resources are at least where they understand what's ahead of them and what they can do to continue to support the people in our communities. We're about to submit our application. It's due on the 5th of April. However, I think we will be ready by the end of next week. It's a competitive procurement with New York State. Awards are meant to be, the state is hoping to make those announcements in June with a contractual date of 8/1. And again, just thank you for the few minutes today, and I'll give Erica a chance to speak as well.
Just 1 second, because we really want this time if there's any questions. I think Karen wrapped it up very nicely. We would just say that this group is an example of how AHI and FDR-HPO have served this region collaboratively and not competitively. I think that Nancy and Bob's work is a great example. We appreciate all you each do to contribute specifically to telemedicine, but we will be, once awards are announced, circling back and definitely folding partners in the most meaningful way possible. But we'll pause there for any questions or things that people have been hearing, perspectives that you want to share. And other than that, a complete slide deck will be shared with you all after this meeting.
Not seeing anything in the chat yet, but yes, please, to all of our participants, if there's anything you want to discuss, if you have any questions about what you've seen so far in communication from our organizations or the state about this process, or just how you'd like to get involved, feel free to place those in the chat now.
And as if you are thinking of anything, and again, once you have a chance to review the slides, it may spark some conversation. But one thing we have heard with some organizations that work across the state, they say that one way that the North Country is very unique is that we aren't siloed. So those of you that maybe have worked in the first district, or you remember that first 1115 waiver that produced a district for our region. In many areas of the state, it was very primary care and even hospital based. Here we had community-based organizations at that table. We've had community-based part of our FIPS, part of our Rural Health Network, part of LIFT grants, and a whole host of things. And so this is an opportunity here to just have a focus on community-based organizations, but not to silo it, to wrap it into all the work we do within primary care, behavioral health, and so on. Anne Marie, I see that you have your hand up.
That was an error. Apologies.
Oh, okay. Well, maybe you're just giving a high five.
I was looking for a thumbs up. Like I agree that you know, district really showed how community-based organizations can integrate in with healthcare and support, you know, support our healthcare organizations. It was really very impressive.
Good, thank you. It may be difficult for questions since it's all new to so many of you. And again, we think that the slides will help give some foundation, but what will be more important is that, you know, after June and the social care networks are announced, that we, you know, circle back in a more meaningful way and kind of hit the ground running.
Yes, thank you.
And our
oh, I was just going to say,
that's
Karen,
the contact information.
Yeah.
It's on
the
the
contact
final slide. Yes.
And then as well, there will be 2 stakeholder sessions. So I'll have the flyer included with our notes in the email that's blasted out to everyone. So if any of those questions do pop up after you review the slides, of course, you could reach out to Karen or Erica directly, but that will be another forum. And, you know, other questions may be asked that you haven't thought of. So it'll be a great opportunity to continue the conversation.
And do we have time? I think Shannon has her hand up.
Yes, I do. Just a quick question, and maybe it can't be answered today, but I know Anne Marie had mentioned earlier that they're going to be they're focusing on, or maybe it was Anne Morgan, I apologize, tracking diabetes, incidence of diabetes, and how our programs have impacted that. I just wondered if anybody can give me an idea of what that's going to look like what data will they be looking at, and how will they be surveying?
I can't answer the surveying piece. I'm not sure. What I could say at a high level, maybe we can better understand the question on the side, but at a high level, these screenings will be for any kind of health-related social need. And then the referrals will be kind of in 4 different buckets that the state will focus on. So we understand there's more than these 4, but the buckets that they're looking at are transportation, housing, care management or case management, and food insecurities. So those would be the ways in which the fee-for-service type new services will be bucketed. So I'm not 100% sure, other than maybe the food insecurities, of how it'll exactly interface with any of the CDSMP or the different types of programs that you've mentioned quite yet. Did that get close, Shannon?
No, well, no, it was good information. Thank you.
Okay.
I appreciate that.
Maybe
I'll stay
Karen.
tuned.
Okay.
Shannon, this is Anne. I can connect with you. We do have a pretty robust evaluation plan. We work with Adirondack Health Institute to support that. And so I'm happy to share that with you so you can see what we're doing.
That'd be great. Thanks, Ann.
Perspective. Yeah.
We are at the top of the hour, so I want to thank all of our presenters today that took the time to share this very valuable information. Again, to all of our participants, thank you for joining us. And if any questions do come up after we leave the session, the recording will be shared along with the slide decks and contact information, so you could follow up with any other questions that you may have. And then just finally, our next Learning Collaborative will be hosted on May 20th from 2 to 3 p.m. That will be in the the notes as well. And we also have a new form for anyone interested in sharing any of your work that you're doing with telehealth and you'd like to present. Please fill that out, and we'd love to have you join us and present on that. So additional information will be included in the notes, some upcoming educational opportunities and some great resources from our other partners. So be on the lookout for that in the next day or so. And everyone have a wonderful rest of your afternoon. Thank you all.
Thanks, everyone.
Thank you.
Thank you. Thank you, Nancy.